Today we're doing something a little different. I have the breast 4 malignant lesions 1 slides up, and we actually are connected with WebEx, so we might have people join in throughout the course of this session. When I hear people pop on, if I don't have that muted, I'll just ask everyone to keep questions till the end. And I'm actually going to go through these slides with you guys really quick and hopefully give you a little bit of guidance of how to go through these things. But otherwise, everything's going to stay exactly the way it has been every other time we've done it. So let's get started. Whoops. All right, so by now you guys have seen this disclaimer a few times. Obviously, when the video is posted, you can pause on this if you want to read up on it. I'm happy to answer any questions that you have about it. It's just a quick little disclaimer that I wrote up. Okay, so what are we going to talk about? Well, today we're going to do mostly carcinomas, maybe some lymphomas, some metastatic lesions. Sarcomas we really covered in the previous lecture, which is breast 3 stromal lesions. So if you're curious about sarcomas, I'd go check that out. And just as a reminder, we only do a few cases, so this is by no means the spectrum of everything that you're going to see. All right, let's get started. So this first case, what I notice at low power is I have a lot of little round blue glands and maybe in a bit of a sclerosing lesion. So I'm just gonna hop in high view, take a look at this. And what I see right away is that these glands are irregular, and by irregular, I mean they're not perfectly round. Some of them are kind of squished, they're kind of pointed. They're not forming a definite lobular unit, which would be a nice round unit. So okay, I'm already in the cancer zone. And even, look at this, maybe a little bit of a desmoplastic reaction. Kind of hard to tell when the stains used in these slides are not my own slides, so sometimes the stain can be a little funny. Okay, so what I'm noticing first off is, so almost this entire lesion, if I go back out to low view so you guys can see, almost the entire lesion is trying to form glands. I say trying because, you know, it is a tumor, so it doesn't necessarily have to be perfect, but it is trying. And so for that, I'm thinking low grade. Then when I go to the actual cells themselves, they're fairly regular. Like there's maybe a few cells that are a little bigger than others. But as I say quite frequently, are they potatoes, are they gourds? So to me, these are potatoes. They're trying to look alike, which in breast is always scary, right? Okay, but it pretty much doesn't matter where you go on these slides. You're going to see the same thing. Relatively monotonous cells with maybe some slight anisonucleosis where the nuclei aren't quite the same size, not quite the same shape. So still low grade. I'd probably give this a 2 for nuclei. And in the handouts for breast, I did put in more information about grading and stuff, and I believe I have information about grading in this presentation too. But okay, so I'm at 1 for tubules, 2 for nuclei, and as I'm surfing around here, I'm not seeing a lot of mitotic figures. And I don't recall seeing a lot of mitotic figures when I first looked at this, so I'm going to give that a 1. So this gives me a total score of 4. I'm calling this a grade 1 tubular carcinoma or invasive carcinoma of no special type. Next case. Again, same thing. This looks like skin at low power. And this looks like our lesion, but let's go check out our skin. So we want to make sure we don't have Paget's. Normally I would stop and pause to see if the residents knew that, but it's just me today. So Paget's, we're looking for irregular cells in the epidermis. So far so good. I'm seeing some, like these are regular melanocytes, which you're allowed to have, but nothing that's screaming Paget's disease, so that's good. Again, if we saw Paget's by itself means that there's likely an invasive carcinoma somewhere, and we're not seeing that, so but we know there's an invasive carcinoma in this case. So whether or not there's paget's, we already know that there's something. Okay. And you can spend more time looking at the skin if you would like, but okay, our breast lesion. So we're going to look in this area. Again, similar thing. Breast tends to be a low power architecture view. And what I'm seeing is kind of similar to the previous one. So anything that we have that's maybe trying to make glands is doing a very poor job of it. It is kind of falling apart in some areas, and that can make things difficult when you're looking at tubule formation. But remember, it's 10 to 75%, less than 10% would be a grade 3, 10 to 75 would be a grade 2, and more than 75% would be a grade 1. So this is within probably the 10 to 75%. So I would give this a 2 for tubules. All right, let's take a look at these cells. Ooh, scary. Okay, so there's a lot more anisonucleosis in this one than the previous case. So we have some smaller cells here. We have maybe even some binucleation going on. There's slightly irregular nuclear contours. That one's almost triangle shaped. Like, what's going on here, right? These are all really irregular. This stuff's not really trying at all to make glands. Okay, so for me, this is getting into the 3. Look at that one. Fit quite a few in there for nuclei. And then, it's a good thing I have notes. Let's see if we can find some good mitotic figures. Maybe there. Hard to say. That looks like one. Okay, one's keeping a ticker going. And with these, sometimes you can spend a good while trying to find mitotic figures. But, whoops, I kicked myself out of the full screen. Let's just go back into that. And, okay. Well, I'm not going to hunt around with you guys for too long here. I did do quite a bit of hunting earlier, and I don't think I annotated slides. So that, no annotations on here. That is something that you can do in the Path Presenter system. If you want to annotate slides, you can do so. Okay. Well, I'm seeing like there's a few mitotic figures. But this thing is so ugly. I have a feeling I called this one a grade 3 when I first looked at it. Maybe a little something that we saw last week, maybe some aspect of lymphocytic mastopathy or diabetic mastopathy here. Because remember, we have like this very glassy island, all these lymphocytes, and then relatively normal looking glands in there. But I think that's an additional finding. This is chock full of invasive carcinoma, and it's too much for me to ignore. My notes say I found quite a few mitotic figures, but I wouldn't necessarily argue with someone if they wanted to call this a grade 2. It just looks too ugly to me to sit there, but okay. So we have our low-grade tumor and our high-grade tumor. So again, ductal or no special type. This accounts for 3/4 of all your invasive breast cancers, and almost all of them are going to be women. At 1 out of 100 cases you'll have will be a guy. They're going to be average age of 60s, and obviously incidence will increase with age. I have in here like your peak incidences for your hormone positive, your HER2 positivity, and your triple negatives or hormone negatives. Well, that could also just be like HER2 positive, hormone receptor negative. But okay, point being, 50 years and up. If you have breast cancer in a younger female, really think about genetics. They tend to be more aggressive. lower thresholds to treat. Okay, grossly, they're going to be spiculated, irregular, usually tan white. Sometimes they're a little yellow, but they're not going to be as yellow as the surrounding fibroadipose. If they have calcifications in them, they'll have that really gritty feeling to them, and they will go through your blades like crazy. Here's a nice, probably 2x photo of invasive ductal. Okay, a little bit in here about your luminal A and luminal B, HER2 positive and basal-like or triple negatives. So very quickly, your luminal A and B are very similar, the difference being that your luminal Bs tend to have higher proliferation rates, and they may or may not have HER2 positivity. Your luminal A should not have HER2 positivity. Your HER2 positives, by virtue of the name, do not have hormone receptors, so you should not see ER, PR positivity in those, and these tend to be high-grade tumors. Your basals are almost always grade 3 tumors. They're going to be very scary looking. All this down here, this is grade 3. And remember that with a lot of these tumors, you can get those lymphocytic infiltrates, which can make life very difficult when you're trying to figure out, is this invasive, is it DCIS? So keep that in mind. If you're really not sure if something is invasive, minimally invasive, or ductal carcinoma in situ, lobular carcinoma in situ, don't be afraid to put your myoepithelial markers on there. If you're not sure if it's DCIS, LCIS, run your ECADHERIN or your P120. Do what feels right within your comfort zone. Okay, a little more information. So obviously I said your luminal A's are going to be hormone receptor positive, so androgen receptor positive, and they should be HER2 negative and Ki low. Your luminal B's should be positive here, but these may be weak because they're starting to get a little uglier. You can have HER2 positivity, and in these, keep in mind that your HER2 positivity can be heterogeneous. So you could have areas that are definite HER2 3+, so positive, and then you can have other areas that are really wimpy, 1+, or even 2+, where you're considering running the dual-ish. Or you might be in an area that does both. You could be in an area that does FISH. So all these things are possible. This is just a smidgen of the molecular that can go on with these tumors. So obviously BRCA1 and 2 are your most important, the highest increased risk of developing cancer over a lifetime, but don't be afraid to run molecular to check for all these other things. As far as differentials, there's lots of things in there, like there's ductal carcinoma in situ, sclerosing adenosis, radiosclerosing lesions, MGA, we saw how scary that can be. And obviously when you're looking at more poorly differentiated carcinomas, think of your lymphomas, your sarcomas, your metastatic lesions, and last but not least, always, always, always consider melanoma. Okay, what are they going to do? Well, they want to take it out, and if they do a lumpectomy, then they're also going to do, they may do systemic therapy, which could include hormones if it's hormone positive. They could do chemo. If they do a lumpectomy, they'll consider radiation. If it's a really large tumor, really angry looking tumor, they may do radiation even with a mastectomy. So there's lots of things that are considered at the tumor boards, and that's why these are multidisciplinary. Prognosis, obviously your luminal A has your best prognosis, and your triple negative has the worst prognosis. Your grade and stage will also affect your prognosis. Obviously, if you have a grade 1 tumor, that's going to do better than a grade 3 tumor. And as we noticed, luminal A, they tend to be low grade. So they tend to be grade 1, maybe grade 2. And your triple negatives tend to be grade 3. So it just kind of stands to reason that the molecular also gives you an idea of the overall prognostic factors of everything. So this is lymph node invasion. We have imaging here. There's some thickening of the breast. Here you have an axillary lymph node that's completely taken over. And here's some calx and another irregular mass. All right, so I did put a little bit of this in here. So this is the modified Richardson-Bloom, which is a modification of the Nottingham scale. So this is how we grade breast carcinomas. And you can follow all this. We kind of went over this a little bit. I maybe should have said like grade 2, or sorry, a 2 for nuclear polymorphism means that the nuclei are increased in size and there's some variation, but you're not going to have bizarre atypia, right? You shouldn't have like things that are like multinucleated, really crazy looking, and the mitoses also kind of follows suit. However, what you need to keep in mind with mitoses, and probably the best easy source to figure out where your microscope fits is the WHO Blue Book for breast, because they do have a really nice table in there that breaks down, if this is your field of vision, this is how many mitotic figures you're allowed to have for each indication. So whether your mitoses is a 1, 2, or 3. You take all that at all these 3 numbers, so your tubule formation, nuclear polymorphism, and mitoses, add that up, and your final number is your grade. Okay, so the caveat I put on 3 is that even though this looks really wild, it's solid, so there's no acinar information. You're only getting a small snapshot of this, not seeing mitoses. However, it would be really unusual to have this kind of phenotype and not see a lot of mitotic figures. As a side note, make sure you do not include apoptotic bodies in your mitotic count, because these often appear very hyperchromatic and it can be difficult to delineate apoptotic bodies from mitotic figures sometimes. So always go by like the general guideline of, would you be willing to show like first, second year medical students, so someone who's just done their histology, this is a mitotic figure. And if you're okay showing them that and saying this is a mitotic figure, then that's probably a mitotic figure. All right, next case. So again, same thing, I'm seeing a lot of pink up here, a little fat, and there's a decent amount of blue. So this is probably our lesion. So let's just go through, and what do we see? All right, so I'm not seeing really acinar formation like we saw previously. I'm sure some of you are looking at this going, I know what this is already. But for everyone else, let's go through this a little slow. So one thing that I'm noticing is these kind of cords of cells are coming through. And if we go a little higher power on them, what we see is that some of them almost look maybe like pennies or coins on their side. I'm trying to hit all the buzzwords. Unfortunately, this is as high as this slide goes for magnification, but you can see that there is some stacking, maybe single filing. There's some single cells that are just kind of percolating through everything, and there's some intracytoplasmic mucin here, so you can see like a droplet there. Maybe there's one there where it kind of almost gives it like a signet ring cell look. There's another one. Okay. Excuse me. But so this is enough for me. You can just cruise around a little bit. You can see how scary this is, where it goes into the fat, and it really likes to fool you. The scariest part about these tumors is after they've been treated, where they basically disappear. But if anyone knows the answer, they can shout it out. If not, I can tell you guys. Okay, not hearing anything, making sure I'm paying attention to everything up there. Okay, so this is an invasive lobular carcinoma, and like we did, so lobular carcinomas don't make ducts by virtue of their name, right? So it would be very unusual to give a tubular formation score of less than 3. So they get a 3. Then when we look at the nuclei, even though some of them are squished, they're relatively the same size. They're very bland. We can't go higher to see much else, but they're relatively the same shape, size, intensity. So you could go 1. I wouldn't argue with you if you wanted to go 2 on this. And then there's like no mitotic figures. So it gets a 1 for mitoses. So I put this as a grade 1 lobular invasive lobular carcinoma. But if someone really wanted to say grade 2, again, I wouldn't necessarily argue with them. Okay, next case. So kind of the same thing. We see there's a lot of fibrous tissue, maybe some fibroadenomatous change, and this is probably our lesion, but let's just check out what this looks like first. And we start seeing stuff almost immediately, but let's go to the meat of the issue. You guys start seeing that now, how we still have the single filing. These cells are maybe a little more eosinophilic. Hey, look, there's our mucin that's hanging out. There's some more. Really helps you when you aren't sure, because sometimes you can have invasive ductal or invasive carcinoma, no special type, that will have these squished glands, or they're kind of on their side, like they're tangential, and it can really look like lobular carcinoma, even though it's not. With this one, we have all these single cells. They're definitely lining up. We have the intracytoplasmic mucin. So this again is another lobular carcinoma. If we look at the cells, and this one we can scan in a little higher, we start seeing, whoa, there's some weird looking cells. So I can't call this a 1 for nuclear pleomorphism. We're still at the 3 for tubule formation. And again, there's not going to be a whole heck of a lot of mitotic figures from what I remember, but everyone, again, please spend some time on these. And so this one, I feel comfortable calling a grade 2 lobular. Looks like we have some biopsy change. Maybe this was an area they had sampled before. But the pleomorphism is just it's a little too much. The cells, like, there's definite differences between them. So going 3 for tubules, 2 for nuclei, and 1 for mitoses is giving us a 6. So this is a grade 2 invasive lobular carcinoma. So if we go to our slides about invasive lobular, these really only account for 5 to 15%. Now, you have to keep in mind that 75% of all invasive breast cancers are going to be invasive ductal or invasive carcinoma of no special type. So this is actually the most common special type of breast cancer because it is not a ductal carcinoma. Again, we're looking at women that are at least 50 years old, and yes, there's always rare cases of men in there, but predominantly it's going to be women. Something to keep in mind with this, and it's maybe something that some of you would have gotten a sense of when I said, they almost look like signet ring cells, is that there can be association between invasive lobular carcinoma and hereditary diffuse gastric cancer syndrome. So remember that you have the CDH1 mutation, which is related to Herceptin, and but it has to be a germline mutation. So if you have a tumor mutation, that doesn't count, okay? It has to be germline. Okay, lobular. So they don't form lobules. They don't have these like masses that fill spaces and expand spaces. So we're not going to expect to see a well-defined mass. Once in a while, you can have mass formation with lobular carcinoma. So, if you have a mass, that doesn't mean it's not lobular. And if you don't have a mass, that also doesn't mean that it's not lobular. But when you're grossing these, you want to make sure that you're sampling fibrous areas, just because it could just be those little trickles of malignant cells going through, and especially if the patient has been treated, these cells really will shrivel up to almost anything, to almost nothing, and then that can be very, very challenging diagnostically. Lobular carcinomas, so they're more likely to be multicentric than other malignancies, but you also have to consider, is it truly multicentric, or is it just that, we're not necessarily seeing an area right between things? Hard to say, but these are very tricky tumors. Okay, most of the microscopy we went over already. You may or may not see desmoplasia, you may or may not see LCIS, and when you see LCIS, if you have a low grade invasive lobular, you would expect your LCIS to be classic type, low grade. If you have a widely pleomorphic invasive lobular, then I would expect to see pleomorphic LCIS. They kind of go hand in hand. You can see LVI, but this doesn't happen that often, to be honest, where it's like significant LVI, and even your nodal mets. More often I've seen like isolated tumor cells, which clinically don't really mean anything, than like micro or even macro metastases. Okay, so the cells, they can be round, they can be more ovoid, they can be more polygonal. It kind of depends how the tumor is arranging itself. We did talk about the cytoplasmic mucin and how it mimics signet rings, so just keep that in the back of your mind. And if they have a lot of abundant cytoplasm, they can even mimic histiocytes or granular cells. And remember, there is a histiocytic subtype of invasive lobular that I did a short review on, so if you're curious about that, you want to see a case of that, make sure you go check out the short review for histiocytic invasive lobular. Okay, classical are almost always grade 2 or intermediate grade. You'll have your single filing, and something that we didn't really see, because we didn't really see benign glands, is that you can have this circular arrangement. So you'll have benign glands, and then you'll have this concentric arrangement around a gland of the little either single cells or the filing of cells. So that's something that can clue you in, and it'll still be these kind of cells. So it's not going to be something that will mimic PASH or fibrinoma. So it should draw your eye, particularly at lower power. There are alveolar rearrangements where they're more discohesive, and this is the one that will resemble LCIS more. And there's also a solid variant, and this is where you really start thinking about, is this lymphoma, metastatic melanoma? And of course, we always have mixed patterns where it's a little bit of everything. For your IHC, most of these are going to be ER/PR positive. Your mucin can be positive, obviously GATA3, and GCDFP15 for breast origin, if you were considering, like, is this a metastatic lesion or lymphoma or something like that. They almost always will be negative for HER2. Obviously your E-cadherin, and if you're worried about signet ring cell carcinoma, then your CDX2 is going to be negative as well. We already mentioned the CDH1 mutation, which is your E-cadherin, and that's located, or a loss, of 16q, which is 16q22.1. It can have your low-grade neoplastic gains of 1q and 16p, and then there's a lot of other associations that you can see. The HER2 mutations are rare, and that makes sense. Rare mutations, rarely going to see it positive by IHC or FISH or ISH or whatever you're doing. So all that goes hand in hand. Our differential are things that we've already kind of talked about. So is it going to be like a mixed type carcinoma? Is it going to be a signet ring carcinoma, lymphoma, metastatic melanoma, and epithelioid variant of myofibroblastoma, which we went over in the last session, which is, again, breast 3 stromal lesions. So make sure you go back to that if you're going, what's a myofibroblastoma? What's this epithelioid variant? How can this look like invasive lobular? The treatment pretty much is going to be exactly the same as ductal or no special type. Your prognosis, so they have a slightly increased risk of contralateral carcinoma, and lobular actually likes to metastasize to the meninges as well as GI mucosa, GYN tract, bone. But lobular with meninges, that's the one to really remember. And over here, you can see how these are really, really sneaky. These are your cancer cells that are within the fibroadipose, and they've almost disappeared to nothing. So chances are this was a treated case. But just like when we talked about bone soft tissue, and we were talking about, is this a well-differentiated liposarc? Is this an atypical lipomatous tumor, right? Remember those, we have those two together. You also want to consider, is this an invasive lobular? So always look at the fat, be skeptical. Okay, a little bit about grading here. So this is just some examples. So you can see very bland, and then we start getting maybe a little more anisonucleosis, and then we get into crazy stuff where it's like, what are all these mitotic figures? Like, usually you don't see much mitoses in lobular carcinomas. You can also see how it's starting to be more solid, starting to be a little scarier. So just things to keep in mind, and a lot of this is in the handouts too. Okay, looking at this at low power, what we see immediately are lakes or pools. Calling it now, that's mucin. Okay, and this is not a biopsy, so this is an excision. Important to keep that in mind. And what do we have swimming around? Kind of weird, but that's okay. Let's just keep looking around. A little more atypia. More atypical, more atypical. Pretty sure there was an area that looked pretty crazy when I first looked at this. Okay, so I can talk as I drive, right? We can do two things at once. Chew bubblegum and pat our heads. Yeah, this is going to be too much. Keep that out. I can see how everyone else does it during the session, so I'm guilty too, guys. Don't worry about it. Okay, so what I'm seeing with this is we have these clusters of not wildly atypical, but atypical cells. Oh, look, that one kind of looks like a little capillary extension that are swimming in these pools of mucin. And the atypical cells are only in the mucin pools. They're not really attached on their own, which probably means that they've kind of fallen off into this. Alright. A little more lymphocytic lesions. Okay. Yeah, ugh, look at that. Too atypical. Alright, so what we have is atypical. These are lesional cells, and too much for me to, and too much and too big for me to say, like, am I still in like the ADH realm? So this is way too much. They're swimming in all this mucin, and everything's detached. And all this atypical stuff, none of it is attached. Maybe this stuff is. I'm just going to keep knocking that out. That's okay. I'm sure everyone sitting at home right now is laughing. Ooh! Oh, look at all that apical snouting. No, we're left off though, so I'm going to leave that alone. I really don't like calling FEA if it's not really there. But yeah, this is atypical. Okay, so when we have this amount of atypia, they're swimming in mucin. It's making, if this is, let's say this is the entire lesion, everything looks like this. There's nothing that doesn't look like this. Then this is mucinous carcinoma. Is that it? Are we done? Can we go home? Well, maybe we should learn a little more about mucinous carcinoma first, right? So we don't see these all that often. 1 to 7% of invasive breast carcinoma. Some people will call this colloid carcinomas. That's perfectly acceptable too, so don't be confused if someone says, oh, it's colloid carcinoma, and you're like, no, it's mucinous. They mean the same thing. These tend to, again, are slightly older patients, and we can see them in very young patients. So when they're under 35 years old, that's going to be 1%, that should be moved over. And if they're older than 75 years old, then that's going to be 7% of invasive breast cancer. So 7%, that's a significant chunk of it. So always keep this in mind. So they're relatively well circumscribed. They're going to have all this gelatinous stuff inside them, and they can be firm, but because of the gelatinous material, they're not going to be hard. Okay, so that's in part due to the mucin that's there, and also because if you saw, everything was inside those mucin pools. There was nothing that was desmoplastic. So that's kind of what we just said here. So they need to greater than 90% of the tumor. Well, pretty much all of what we were seeing has to be completely surrounded by abundant extracellular mucin. You can have fibrosepta, which will compartmentalize it, and that's how you get like the well circumscribed lesions. And we can also have the epithelium that's detached and floating in the pools. We didn't have nice big chunks like this, but everything was floating in those pools, and you can see the delicate septate in between. This one's a little more robust. The tumor cells are relatively low grade, so again, where you're thinking, is this ADH, is it DCIS? So you're in the low grade field. They tend to be well to moderately differentiated. You can rarely see poorly differentiated in these, so less than 1% of these will be poorly differentiated. So less than 1% of 1 to 7%, that's really rare. You're also not really going to see lymphovascular invasion or lymph node mets. So if you're seeing these things, I'd reconsider what you're looking at. Maybe you're seeing something else. Two types of mucinous carcinoma. So the first one is what we had. So that example is a type A mucinous carcinoma. It's paucicellular, so there's not much going on, and there's a lot of mucin. The difference is type B, there's a lot more cells. There's still a lot of mucin, and mucin still has to surround all the clusters. But you're going to have a lot more cells in there, and type B, even though it's really cellular, they actually have a decreased incidence of lymph node mets. So when we consider that's already a rare phenomenon, and then we take type B and we say, well, it happens even less in these. Again, if you're pretty sure you have type B mucinous carcinoma and you have lymph node mets, maybe reconsider what you're thinking there. Okay, and then here's the caveat. So if greater than 10% of your tumor, because remember we said greater than 90% has to be surrounded by abundant mucin, if greater than 10% of that is non-mucinous, then you want to classify it as a mixed tumor. And it stands to reason that most often it's going to be your ductal or no special type, but you can also see it with invasive lobular. And why does it make sense that's no special type or ductal? Well, if 75% of your invasive tumors are going to be invasive ductal, then it makes sense that the most likely tumor that you're going to see adjacent to or admixed with your mucinous is going to be invasive ductal. Also, again, we don't have desmoplastic response. So if you have stromal invasion in the absence of mucin, then you also want to classify it as a mixed mucinous tumor. Stains, whole bunch of stains. Really the important thing to note is that your type B can be positive for your neuroendocrine markers. And obviously because of mucin, here look, we have lots of mucin. Wnt1, beta-catenin, that should tell you that the beta-catenin and Wnt1 pathways can be involved with things. But honestly, the molecular is not too helpful. Usually you can diagnose these on morphology alone. Okay, so mucosal-like lesions. So this is what we're going to call if we have a biopsy or if it does not meet criteria for mucinous carcinoma. Your metaplastic carcinomas can have a really prominent mucinous response. So your myxoid fibroadenomas, so your fibroadenomas can have this really prominent myxoid change. So things that can look like mucin but not necessarily be mucin. It's more likely to be mucin down here, but that's another story. So again, I would think about those versus like your mixed tumors. And invasive micropapillary carcinoma, so if you have micropapillary carcinoma, they tend to have a lot of mucin production as well. Okay, this is going to be a recurring theme. Complete excision plus or minus systemic therapy. So if you have a pure mucinous carcinoma, your 10-year survival is greater than 80%. If you have a non-mucinous or a mixed carcinoma, then the prognosis actually depends on the prognosis of the non-mucinous element. So if you had like the lobular carcinoma where they had a slight increase of contralateral breast carcinoma and multifocal lesions, so that would matter more than the mucinous element. And here we just have it again where it's the type 1 and type 2. It's a little more focused information on that just to kind of drill it home. Okay. And this one. This one's kind of interesting. What do I remember? So, okay, low power, very pink, lesional stuff in here, possibly this stuff too. Let's see what it looks like. Okay. So, the cells are relatively epithelioid. There's fairly prominent cell borders. Maybe it's trying to form glands. Hard to say. It would not be wrong to look at this and first thought be, is this metastatic squamous cell carcinoma? But one of the other things that you should think about is your metaplastic carcinomas. So looking at this, that looks like characterization. So you could go one or two ways with this one, I think. This could either just be a squamous cell carcinoma, metaplastic squamous cell carcinoma, or adenosquamous. Kind of looks more squammy. I think it's trying to confuse us maybe with this, where we have like a little bit of dropout. These are hard lesions though. I don't think anyone who signs out breast pathology will ever stand up and say, hey, metaplastic lesions, so easy. But I think that's kind of the differential to have. It just, to me, looks like there's more dyskeratotic cells in here than anything, but those kind of like acinar areas or cytoplasmic. Are they vacuoles? Are they, I don't know. They could be lumen. They could be, no, they don't look like that. But there, we struggle with things. That's what normalizes all of this, right? Nobody's struggling alone, we're all struggling with it. Okay, and then this stuff that I was worried about, this just looks like lymphocytes. That love to confuse us even more. Yeah, that looks dyskeratotic, that looks dyskeratotic. Okay, I feel better saying like maybe this is more squamous. I did also do a video of metaplastic carcinoma that was a squamous cell carcinoma. I think that one looked a little more squammy than this, but these look very squammy. But this would be in like the poorly differentiated at best. Again, if somebody's watching this video at some point and disagrees with me and wants to go more adenosquamous and tell us why, I think that would be fantastic. There's nothing in here that says, okay, I'm like what I say is gospel truth, so question things, and if you look at something and you're like, hey, I think because of these points we should call something this, or I would grade something that way, I would love to hear that, because that's really how we improve with all these things. Okay, so I just went metaplastic carcinoma, and it looks like I mostly went squamous cell. Hey, this kind of looks like our lesion, right? So these are uncommon. Less than 1% of invasive breast carcinomas, and metaplastic lesions basically look like other carcinomas or other adenocarcinomas, but they don't look like breast. These happen in adults, and the incidence is like breakdown is similar to other invasive breast cancers. And these tend to be very large lesions, so they're palpable, and patients will feel them and be like, oh my gosh, what is this? The clinicians will feel them, they'll want to get a biopsy of that. These tend to be fairly significant, 1 to 10 centimeters, 2.5 to 4.5 centimeters. These are not small lesions. They can be lobulated, partially circumscribed. They may even have calcifications. Okay. That last case, I think, had a little bit of DCS on the one biopsy, but if you see DCIS, that actually supports that this is metaplastic breast carcinoma, and it's broken down into 3 different areas. So you have your carcinomas with squamous and/or spindle cells. So that's your squamous, spindle cell, adenosquamous, or low-grade carcinoma with fibromatosis like stroma. There have been a few of these that have been posted on social media lately where people have been wondering about fibromatosis like lesions, and definitely always something to consider. You have your matrix producing carcinomas, so that would be like things that are producing like osteoid or mucin, like we were talking about with the mucinous carcinoma. And then we have our carcinosarcoma, or if you really want the mouthful, carcinomas with true malignant mesenchymal components. So you're going to have a carcinomatous element and a sarcomatous element. So just mash your favorite carcinoma and favorite sarcoma together, and that can occur in the breast, but obviously these are already very rare tumors, and you're looking at something that's even more rare, so keep that in mind. Okay, so it looks like I did a lot on squamous cell here. So squamous cells centrally located, so these tend to be either under the nipple, or they can be beside a cyst, and they tend to be associated with obviously some metaplasia. So this can be associated with inflammation. So you'd want to think about things that can cause inflammation to the breast. So one of the things that comes to mind when we think squamous metaplasia is always smokers. For some reason they get a lot of squamous metaplasia in their breast ducts. Also anyone who had like recent mastitis, or someone who's maybe been breastfeeding for a while. So you want to think about all these kind of things. And know that your metaplasia can even involve your myoepithelial cells. For squamous, you have the entire range of squamous. So are they keratinizing, are they basaloid? Are they well differentiated, poorly differentiated? You can have acanthodic growth patterns. You can have things that resemble angiosarc, and things that look kind of like PASH. With these metaplastic lesions, though, your lymph node mets are actually really rare. So when we think about squamous cell carcinoma, it loves to go to lymph nodes. If you've done an ENT resection, I'm sure you found a lot of squamous cell carcinoma in lymph nodes. Positive stains. Okay, so things that make sense, right? Your keratins. So CK5-6, your 34 beta E12, because it has the CK14, your P63 SMA, CD10, P-cadherin, not E-cadherin, P-cadherin, and because these are not breast adenocarcinoma, right? They're a metaplastic lesion that's occurring in the breast. They're going to have the triple negative phenotype, so they're going to be hormone receptor negative, HER2 receptor negative. So on, like, if you did like a mammon print on them, or you did an Oncotype DX or whatever, these are going to fall under the same realm as your triple negative breast cancers. Your molecular, so you have the one gain of 1P, gain of 5P, and loss of 3Q are actually your most common mutations. You can see that your PI3K AKT pathway changes, loss of P10, loss of CDK N2A. EGFR amplifications can be seen. And obviously your differential at the top is going to be, is this squamous cell carcinoma that's originating in the skin? Depending on, so these less likely to look like squamous cells, so this would involve the other types of metaplastic carcinoma. So Foley's tumor or fibromatosis, if it's something that looks more like fibromatosis, you can have adenoid cystic carcinoma. There's another short review that I've done there on adenoid cystic carcinoma. You can have pleomorphic adenoma. You can have primary or metastatic sarcomas. And of course, what's missing from this list is melanoma, right? Because you can have spindle cell metaplastic breast carcinoma, so this would be the more spindle cell. So then you need to think about things like melanoma as well. So there's really not a lot of data on these because these lesions are so rare. So they don't really know what to do with them beyond surgery. They may or may not give them systemic or adjuvant therapy. But the NCCN guidelines don't say anything specific about treating one way or another with these because they just don't know. There are enough numbers. And same thing with the prognosis. Like there's speculation that these tend to do worse, but we don't really know. If you have one case of metaplastic breast carcinoma, but you have 1 million cases of invasive ductal, you can trust the numbers that you're getting for the invasive ductal. I wouldn't trust the number off of one case of metaplastic breast carcinoma. And obviously we've seen more than one case of these, but the numbers aren't necessarily statistically significant, and it's not even that they've necessarily been able to follow these patients long term or figure out how they do with different therapies. Sometimes they're lost to follow up, and all sorts of things go on. So that's why you need a high N number or a large amount of cases to really say anything about all these things. Lymphoma, okay. I'm going to call it now. HemePath is not one of my strong suits, but we will do our best. Okay, so if I didn't have this little bit of breast tissue down here, I'm still not entirely sure, but at this view, you almost wonder if they gave you a lymph node. So that's one of the first things that you should think about. Is this a lymph node or is this actually in breast tissue? And it looks like it's relatively the same going through. So let's just go down. Okay, and we're in breast tissue. These are tiny little lobules, but those are normal lobules. And see a blue, that's always a scary sign. We don't have capsule, we went straight into breast tissue. And the other thing I'm not really seeing, we're seeing a lot of germinal centers. So even if this was supposed to be a lymph node, we don't really have germinal centers. Okay. Now, when you're looking at lymphoma, pretty much if it's in the breast, better than a coin toss is to say diffuse large B cell lymphoma. And that's because 60 to 80% of all lymphomas, primary lymphomas in the breast, will be diffuse large cell B lymphoma. Now, when we look at the morphology, how we can say that is this is a lymphocyte. These cells are nowhere near the size of a lymphocyte. They're huge compared. We've seen other cells and other lesions that are much bigger, but lymphomas means, they're lymphocytes, they're lymphocytic, and these are so massive. Like you could probably put 4 or 5, maybe even 6 lymph nodes in one of these. So if that isn't enough to convince you of DLBCL, and it's a sea of them. Now, maybe you could argue, hey Kara, I think, what if this is a poorly differentiated carcinoma? I think that's a fair thing to say. Someone hopefully is chiming in at some point saying, did you forget about melanoma? which we have not. And this is also as high as you can zoom in on this case. But you can see like there's prominent nucleoli. Anyway, so okay, well, you can run your B cell markers, and that's pretty much what's going to tell you that this is a diffuse large B cell lymphoma. Off the top of my head, so that would be things like your CD20, CD19, maybe CD43. Again, like I said, not necessarily my strong suit. Pretty much any age group can get this bimodal peaks. So 30 years old, 60 years old, it's breasts, so women get it a lot more than men. Like every other lymphoma on the planet, fleshy gray white mass, average of 4 centimeters. You should not see calcifications in these, which kind of makes sense. It's a lymphoma, so lymphomas don't tend to be calcified. And what you can see is these discohesive sheets. So discohesive sheets, it's kind of like saying like you have like these clefts around cells that don't make sense. It's not because it's poorly fixed and it's falling apart. It's just falling apart. And I think that's easier to tell if you have an area that's really well fixed, but like you still have that clefting and falling out appearance. Again, look, it's going to mimic your poorly differentiated carcinoma. Can also mimic your inflammatory breast carcinoma. Oh, and this note is in here. Recall, this is a clinical diagnosis, so never, ever, ever, and you know, we always say like never say never. There are no absolutes in pathology. This is an absolute. As a diagnosis, like on your top line, your diagnostic line in breast, you cannot call inflammatory breast carcinoma, okay? The clinician will call that. You can say something in your note about like, well, this would be a stage T4D, clinically, like clinically inflammatory breast carcinoma or something like that. But as a diagnostic line, you cannot call inflammatory breast carcinoma. What else? So this is a lymphoma, and if you have involved lymph nodes, you can have blockage of your lymphatic fluid. So you could have edema not only in the breast, but in the arm as well, on the same side. Okay, well, I didn't do too bad. Okay, so P20, 79A, and PAX5, right, because PAX5 would be your immature B cells. So the caveat to your negative stains is that there's no DCIS, right? This is a lymphoma, it's not a breast carcinoma, so your hormone receptors are going to be negative, HER2 should be negative, and again, it's lymphoma, so keratins should not be negative. Or keratins should be negative, sorry. Keratins negative, CD20 positive. For molecular, you can see MYC translocation in about 40%, so that's a decent amount. And chances are, if you saw this lesion and you sent it over to HemePath, that they would run it for MYC translocation. What else? So, okay, lymphomas, so you need to differentiate from acute leukemias. Your lymphocytic mastopathy, so we've seen that in a few lesions already today, where you can have these really prominent lymphocytic infiltrates, and it can really make your diagnosis of is this invasive cancer difficult. But remember, lymphocytic mastopathy, you're going to have those C's of really glassy, eosinophilic hyaline and hyalinized collagen, and then you'll have those small islands of very intensely blue lymphocytes that should have benign, small, maybe even squish. They might not even have any normal breast ducts in them, but if they have breast acinite within the lymphocytic infiltrates, they will be normal. Okay, lupus, IgG4, so these things are more related to the inflammatory response. Obviously, we have to talk about inflammatory myofibroblastic tumors, so again, go back and review all those things, and then invasive carcinoma with medullary features, so a very high-grade carcinoma, and invasive carcinoma that would, low grade? I don't know about that. But again, your keratins are going to be negative, so that's going to help you out there. Treatment is going to be similar to lymphoma elsewhere, so B cells, so that would be what, like things like rituximab or Rituxan, because that's a anti-CD20. And then prognosis really depends on the type of lymphoma you have. And then they can have relapse either in the same or other side of the breast, and also CNS. Always remember, lymphoma likes to go to CNS, and most of the lymphomas that you see in the brain almost invariably are going to be diffuse large B-cell lymphoma. Okay, metastatic lesions. And I do believe this is our last lesion of the day. But okay, well, you know, they were helping us out a little bit, so we have dots right here, but low power, all right, always start low power. We have all these breast cores, or at least we're assuming they're breast at this power, and they pretty much all look the same. So we can go to their dots. I think we'll start here, and then we can go to their dots. Okay, so regardless of what we're thinking this is, we can tell almost immediately that this does not belong in breast. We have all these strange shaped cells. These ones are spindly. But what's going on with these nuclei? They're very, very irregular. Here's our hint. Is anybody on? Anybody that knows what this is or can hazard a guess? Look at that nuclei. Oh my gosh, that's scary. Okay, so this is pigment, melanocytic pigment. Just really crazy looking cells, but okay, yeah, lots and lots of pigment. All right, let's go up to their dots and see what they dotted. Oh my gosh, it's even crazier. And look how prominent this pigmentation is. Okay, there can be no doubt with this. This has to be melanoma. There really aren't other lesions in the breast that are going to have pigmentation like this. These wild nuclei. Oh my gosh, way too crazy. Okay. Melanoma, second most common lesion to metastasize to the breast. So it actually accounts for 20% of, what is that, 20% of metastatic lesions to the breast maybe? Metastases to the breast actually account for less than 3% of breast malignancies. So these are relatively rare, even though they're the second most common lesion. Almost all of these cases are going to have a known history of malignant melanoma. Grossly, you could see black pigmentation in the lesion. And again, they're almost always going to know from previous biopsies, previous excisions, that this patient has malignant melanoma. So as we can see, like, this would be really hard to say, is this lymphoma? Is this melanoma? Is it a poorly differentiated carcinoma, or maybe even a lobular carcinoma? The pigment helps you, but you can't always rely on pigment, right? It's not always there. It's maybe not even always prominent enough to really appreciate on H&E. And here we can see, like, here's the lesion, here is normal breast tissue. So the stark contrast between the two. Basically, these are lesions that they don't like to make themselves missed. So when it says primary site may be unknown, so if you have like retinal melanomas are actually fairly common in the retina. The GI tract, if you have a melanoma that's sitting in your small intestine as a primary, it could take a very long time before that's found out, and it usually would be because you have metastasis somewhere else, and they either were doing imaging for something and they found it incidentally, or you had a lesion go somewhere else that they were able to find it. And again, they could have a remote history. They could have a history that's 10, 20 years back, and it's cropped up again in the breast. Okay, so your melanoma stains: HMB45, Melon A, S100, SOX10. Negative stains, so again, it's not a breast lesion, so your hormones are going to be negative, HER2 is going to be negative, keratins, GATA3, and your molecular are going to be very similar to whatever the initial lesion was. So you need to think BRAF mutations for metastatic melanoma, and I believe that should be like a V600E, but I think they also have the V600K. Me trying to remember that, but I haven't looked at it in a while. But there's quite a few BRAF mutations, and those would be the most common to occur in melanoma. Your differential obviously is going to be primary breast carcinoma and other lymphomas. And treatment, so they might excise it, they could do systemic therapy, they may do palliative therapy. If the patient has a breast lesion that is metastatic melanoma, but they have lesions all over their brain and their lungs, then that would be when they might just do palliative therapy or palliative systemic therapy. Prognosis is dependent on extent of disease and related to type of melanoma. So generally, it's going to be a poor prognosis. Melanoma itself doesn't have a really good prognosis. And this is just kind of to give you guys an idea of, like, on H&E, you can see the pigments, HMB45, S100, Melon A. If you had a heavily pigmented lesion, what is sometimes done in DermPath is that they will either use like a red counter stain for these instead of brown. You can also bleach slides so that when you do your IHC, it's going to get rid of a lot of the background and let you evaluate those lesions further. I don't think the breast melanomas become that heavily pigmented, but it's always possible. Okay, and that's all we have for this week. So there are 13 cases in there for the challenge. If you are just joining us, if this is the first time you've sat in on one of the unknown sessions or the first time you've popped open one of our lectures, the unknown cases are really just designed for you to have more examples of cases. They're ones that I've gone through and like quickly said, okay, I think it's this. These are by no means vetted by the experts. This is just my quick review. So sometimes it's just, can you form a differential of what you think this should be? Can you try your hand at grading? There's no real right or wrong answers. It's just, I believe that the more you see, the more you're going to learn. So if you're interested in those, take a look at them. If you like this video, hit like. If you aren't subscribed to us already, hit subscribe so that you can be notified when we have new content. We do try to put up our unknown sessions on Fridays and short reviews on Mondays, as much as our schedule allows. If you have suggestions for things we could improve on, things you'd like to see, things that you thought, you know what, there's a better way to do this, let me know in the comments. You can follow me on Twitter. Let me know on Twitter what you think, or again, things you'd like to see. And that's all I have for you. So we'll see you guys next week. If you were part of the WebEx, I'm just going to check here and see if we have any comments. Okay, so no questions. Oh, as I zoom in too much. But if you have the link to the WebEx, we do have that link posted in a spreadsheet that is available through Twitter. So you guys can check that out, and we'll try to be here again every week so that you guys have something new coming in. And that's all I have for you. So thank you for sticking around, and hope to see you next week.